Mm. Okay, it's about time. Good evening, everyone. Can everyone hear me? Yeah.
Yes, we can.
Okay,
Yes.
I'm Yi. I'm from National Heart Centre, Singapore. Thank you for everyone for joining us this evening or morning or afternoon if you are in other parts of the world. Today it's my pleasure to co-chair the episode 6 of the APSC Hot Topics in Cardiology webinar series. And today's episode will be on updates in electrophysiology. In today's episode, we'll be covering both conduction system pacing as well as pulse field ablation. This session is in collaboration with the APHRS and is kindly supported by Medtronic and Abbott. And I'd like to thank them for giving us an unrestricted education grant to run this episode. My co-chair for today is Dr. Sofian, who is the head of electrophysiology in Gleneagles JPMC in Brunei, and I believe also the current president of the Cardiac Society of Brunei. For our panelists today, we have two distinguished panelists, Dr. Koh Keng Tat, who is a consultant electrophysiologist at the Sarawak Heart Centre and also the current chairperson of the Malaysian Heart Rhythm Society. And with us, we also have Dr. Paul Lim, consultant electrophysiologist at the Heart Specialist Clinic in Mount Elizabeth, as well as a visiting consultant at the National Heart Centre, Singapore. We'll introduce our speakers just before their talks. So just some housekeeping rules before we begin. So the content of this webinar is copyrighted by the APSC. The views and opinions expressed are those of the faculty members and may not necessarily represent those of the APSC. This webinar will be live streamed via the Facebook and YouTube pages. And if you do wish to revisit any of these webinars, you can visit the APSC YouTube page. Now there is a Q&A button at the bottom of your Zoom, and feel free to post your questions and hopefully we'll have time to address them during our discussion time. Before we move on to the talk, just a bit of advertisement for the upcoming APSC Congress. This will be held in May in Taiwan, and I hope you can join us there. Okay, and before we dive into the episode, this is just a shout out that there will be a next episode next month, and that will be highlighting lipids in the limelight, modern management, and CVD risk in the middle of April. Okay, so let's get started. So our first speaker is Dr. Ronpichai from King Chulalongkorn Memorial Hospital. So he's an experienced cardiac electrophysiologist who has completed his fellowship in Michigan. As we all know, conduction system pacing has been gaining traction over the years, and today he's going to visit some of the more recent trials on conduction system pacing. Okay, and with that, I hand over my time to you. Thanks, Dr. Ronpichai.
Thank you very much, Dr. Yi, for the kind introduction. I'm going to share my screen real quick. Glad to be the part of this meeting. Hopefully, we can have an update for the CSP. Can you see my screen?
Yes, but it's not in the presenter mode.
Okay. How about here?
Yes, we can see the whole screen.
Okay. So we're going to start the CSP, all you need to know in 2026. So this is the area that I will try to cover, different aspects of the CSP. So some of them is very interesting. Some of them is pretty innovative. But I'm not going to touch about the basic stuff about the CSP, the criteria for the conduction system pacing. That is pretty basic for the most cardiologists and electrophysiologists. But I'm going to try to touch the area that's going to be the future perspective of the CSP, including the ongoing RCT, the different strategies to treat atrial fibrillation ablation. What can we do other than just AFib ablation? We can do the pace and ablate strategies. And we also have the new pipeline lead design for the CSP that can be the dedicated ICD lead also. We can also do the CSP in the setting where we don't have the dedicated EP labs by using the programmer alone. How can we do that? We're going to touch about that. And we're still waiting for the dedicated pulse generator and the program to confirm the capturing of the connection system. And last but not least, we are going to talk about the extraction of the long dwell lead in CSP. So let's start with the ongoing RCT. If you see the RCT with the CSP, you need to divide the clinical trials into two different populations. The first one on the left is AV block patients. The second category is heart failure patients. We have pretty solid evidence to prove the benefit of the CSP in AV block patients. And in the AV block patients who require the cardiac pacing, CSP become pretty much class 1 indication to implant the pacing in this group of the patient, namely the AV block. But the gray zone, when we are getting into the heart failure patients, they are still debating issues to discuss pros and cons between traditional biventricular pacing and the CSP. Which one is preferred over the other? There are so many ongoing RCT comparing between the traditional BIV and the CSP in CRT indicated patients. So let's start with a quick look for the CSPS trial. This is one of the trials that randomized the patient with an AV block into the CSP and the RV septal pacing. So the cornerstone of the pacing in the AV block patient has been shifted toward the CSP with so many randomized studies for the AV block patients. There are hard clinical endpoints to prove that the CSP provide the better clinical benefit in the long-term data, including this one. You can see that the CSP can reduce the incidence of pacing-induced cardiomyopathy compared to those with the RV septal pacing. Get back to the heart failure patients. If you look at the studies of the heart failure patients in the right side of the slide, you're going to see so many studies going on. But one of them that has been pronounced pretty much in the Heart Rhythm Society is CONSIST CRT trial. This is one of the very first randomized studies trying to compare between the CSP and the biventricular pacing. CSP eventually proved or show some signal to provide better benefit compared to the biventricular pacing. However, this is only 12-month follow-ups, and the main number of the population in this study is a very few number of the patients, just published in 2025. Definitely a lot of secondary endpoints, including echocardiographic response, all favor the CSP over the biventricular pacing. However, I think last week on March 11th of 2026, a week ago, JAMA Cardiology published two randomized studies of the CSP versus biventricular pacing at about the same time. If you see the study on the left and on the right, they exactly published on the same day about a week ago. The first one from the Chinese group, as the second one from the Brazilian group. The study design is identical, but the result is very conflicting. So both studies randomized the patient with a heart failure reduced ejection fraction with a left bundle branch block morphology QRS pattern, New York Heart Association class 2 or more into the CSP and biventricular pacing. Here is the opposing result. Let's start with the Chinese group. The Chinese group showed the benefits of the CSP, mainly with the left bundle branch pacing over the biventricular pacing, with 74 risk reductions of the primary composite endpoint in the left bundle branch area pacing. But the similar clinical mortality between these two groups. However, with the Brazilian group published on the same day, they just show the disadvantage of the CSP, mainly with the left bundle branch area pacing. The design of the study is exactly identical to the one with the Chinese group that published on the same day. They include the patient from the heart failure reduced AF, left bundle branch block, randomize the patient to the CSP and BIV with the multi-center studies exclusively in Brazil. So if you look at the Kaplan-Meier curve, you're going to see that the CSP group show more incidence of the primary composite endpoints, about almost 3 times higher than biventricular pacing over a period of follow-up of about a year. And more interestingly, if you look at the top panel, you can see that the group of the conduction system pacing has more incident in decline in LV ejection fraction. This is pretty striking result from the CSP arm. Everybody asked why the CSP group has declined in LV ejection fraction, despite the similar QRS duration reduction between the BIV and the CSP. So what does the message from this study tell us is, if you do the CSP and get a very good narrowing down of the QRS complex with the CSP, it isn't a full proof to guarantee the long-term clinical benefit of the CSP in this group. Why? If you look the graph to intersect between the two study, the physio syncs from the Brazil and the heart sync from the Chinese group, you can see that they are pretty discordant between the result. One, meaning in the Brazil group, still prefer the biventricular pacing for the CRT indicated patients. Why the Chinese group provide the clinical benefit on the CSP in the same population? Here is the thing that we need to keep in mind when we do the CSP in the CRT indicated patients. If you look on the left and on the right, we try to compare the characteristic of the study design, the pacing strategies, and the baseline demographic data of two populations in two different studies. Both studies designed the same way, multi-center randomized studies, with the pacing strategy that is different between these two studies. In the heart sync left bundle branch pacing, they strictly go with the left bundle branch capture criteria, but in the physio sync heart failure studies, they just provide some liberal, meaning that the patient in the CSP arm might get just the deep septal pacing or non-selective left bundle branch area pacing. On top of that, the operator experience in the Chinese group is pretty much well experienced in the CSP, in contrast to the physio sync group that half of the operator might have experience in implantation of the CSP less than 40 cases before enrolled into the studies. Also, the baseline characteristic of the patient in the heart sync has mainly occupied by non-ischemic cardiomyopathy, as opposed to the patient in the physio syncs that half of them has a non-ischemic and about 40% has ischemic. So I think there are three main reasons why these two studies provide opposing result. You look at the study from the China, they strictly comply with the criteria for the left bundle branch captures. The procedure has been done by very experienced operators, and a lot of population in this study is a non-ischemic group, which still gonna be very likely to be the responder for the CSP. So what we learned so from the clinical evidence is a lot of ongoing studies just provide us the surrogate markers, but we're still waiting for the studies that show the hard clinical endpoint in the CSP. There is definitely abundant and sufficient evidence to prove that CSP is going to be the first class 1 for the AV block patients. But in the heart failure patients who is CRT indicated, we still need a lot more data to prove that CSP is equivalent or non-inferior to the traditional biventricular pacing. And from the studies from the Brazilian group and the Chinese group, just for to prove the evidence that we need to strict with the left bundle branch capture criteria if we're going to implant the CSP in the heart failure patients. Now let's move to the quick look at the pace and ablate versus AFib ablation. Why this topic is very important, because we know that in the persistent atrial fibrillation patients undergoing AFib ablation, the first year success rate to maintain the sinus rhythm is just anywhere between 50 to 70%. So they try to compare the ablation and the pacing strategy that try to improve the symptoms of the patient in this group. As we know that the ablation alone might not be the gold standard to treat the patient with a long-standing persistent AFib. This is one of the very first study that kicked off a lot of followers to decide a similar study design to prove the concept that simply might be the better options. They randomized the patient with the long-standing or even the permanent AF with a narrow QRS complex to do the rate control. versus the rate control by ablation and biventricular pacing. These studies showed the significantly benefit of the group who underwent the ablation plus CRT. In this ablation, it means the patient underwent AV node ablation. And it comes to the two main randomized studies that is still ongoing, PACE-5 studies and ABACUS studies. In the PACE-5 studies, they are compared the patient with an AV nodal ablation plus left bundle branch area pacing versus pharmacological rate control in permanent AF and heart failure patients. ABACUS studies has been similar design with an AV node ablation plus CSP versus ablation with a PBI. I think ABACUS studies would be, if the results lean toward the AV node ablation plus CSP, is going to be a big paradigm shift in the AFib ablation eras. But there are still ongoing studies, and I think that few years later, we're going to see the result from the PACE-5 and ABACUS studies. However, to keep in mind, there's not a randomized study comparing between the left bundle branch area pacing and BIV. These two randomized studies just use the CSP as the main pacing modality to compare with the pharmacology and catheter ablation for the AFib. So the new lead design for the CSP. So CSP firstly came out about almost 10 years ago with the leads that first designed for the conventional pacing. The concern of the lead that was not dedicatedly designed for the CSP is the fractures. But nowadays we have a lot of evidence to prove that it's safe enough to use the current lead design, which is already been used in the market for 10 years for the CSP. And this is the ICD leads that some author just try to screw the ICD lead. ICD lead is 8 French through the 9 French of the St. Jude Medical to penetrate into the septal. Most of the patients who require the pacing and ICD at the same time will get the benefit by minimizing the number of the leads across the tricuspid valve. And I know that many companies, and they are developing the leads that dedicated for both pacing and defibrillation at the same time. So what about the success rate when you modify the ICD lead to implant a CSP? The success rate is about 60% because of the delivery system is not that good to maintain the coaxial between the projection of the tip of the lead and the intraventricular septums. So that a lot of operators struggle to advance this ICD lead into the septum, not just because of the delivery system, but the bigger caliber of the ICD lead might be the challenging issues when we try to negotiate to get the lead into the septum. Let's go to the dedicated EP recording system. I think most of the clinical setting, they have the EP labs that equipped with the EP system that you can record 12 leads EKG, local electrograms, but many parts of Asia Pacific regions implant the CSP without that dedicated EP labs. And they can do that. They can do that by modify the programmer and hook the patients with the red dots in the pictures. By using this, you can have some leads as the surrogate markers of the V1 and V6. However, I know that many parts of the regions try to do this, but the caveat is there's no standardized of lead placement for now. You still need to have the quality control with a standard 12 leads EKG or EP system before adopting the modified version of the programmer to assist the CSP implementation. And there are still some data to show the good agreement, but measurement errors when you measure the LVADs or intrapeaks interval in the programmers. So these are caveats that you need to make sure that you are aware of this limitation when you perform the CSP implantation. With the AV block patient, it's fine to use these modified versions, but in the patient who really needs the left bundle branch captures, like the CRT indicated patients, you might need something that is more granular measurements like the dedicated EP lab systems. Still, we are still waiting for dedicated pulse generator to ensure the capturing of the connection system pacing. It's going to be coming out soon. And extraction is not that bad also. So everybody concerned that when you implant the lead into the septal and take the lead out, it might cause the ventricular septal defect, but it's not that bad though. So we have the studies but about the lead extraction in the CSP with the longest follow-up period, like 2 or 3 years. I know that we are not talking about 10 or 20 years of the lead extraction, but so far with the evidence of 2 or 3 years, it's fine to pull the lead out with some assistance from the mechanical or laser sheath without any bad sequelae to the point that we need to have the operation to fix that, like the hole in the septal. One last thing is very the things that we need to talk about is next era of the connection system pacing is a Bachmann bundle pacing. So the idea of the Bachmann bundle pacing is you pace at the conducting fiber that link between the right atrium, the left atriums. By having the restoration of the synchronization between both atrial chambers, you're gonna get the better atrial function, better timing of the atrial filling into the ventricles, provide a clinical improvement of the heart failure patient, and also with the lower incidence of the atrial fibrillation. There's still ongoing trials to prove this concept. So in summary, I just want to emphasize the ongoing RCT, waiting for the study that mainly focused on the CRT indicated patients. Be focused on the left bundle branch captures when we perform the CSP in the CRT indicated patients. In the next era, long-standing persistent AFib ablation might be downgraded into 2A, 2B. And if you look at the PACE-5 studies or ABACUS studies, PACE and ablate strategy might become a better solution for this group of the patients. We are still waiting for the newly designed for the EP system and the generator. Also, the extraction is a thing that need to wait for the decades later. The Bachmann bundle pacing is the thing that we cannot miss it and try to stick on the clinical studies. Thank you very much.
Thank you, Dr. Ron, for the great coverage of the latest updates in CSP. I think the left bundle branch and HFrEF contrasting trials really is quite interesting, and I was thinking perhaps we could start there, and if I could invite the panelists to see what comments they have about that. What do they think about these two contrasting results, and what's your current practice?
Yeah, great talk, Ronpichai bro. I think very detailed talk. I thought you'll talk more than 30 minutes or to 1 hour, but you have managed to shorten it to 20 minutes on time. Yeah, but I'm also very interesting about this the PhysioSync and the HeartSync trial that you mentioned. It's a very contradicting trial that published at the same time. I tried to dissect it very in detail, know what's the difference between these two trials. What do you think? Do you think what makes one trial to have a positive result, another one have a negative result?
Yeah, so between the HeartSync and PhysioSync, I think it's just all about the capturing the left bundle or not. If you see the PhysioSync, you see the similar degree of the QRS reduction between the CSP and the BIV from the Brazil group, but they cannot show the clinical benefits by just looking at the QRS duration reduction. So I think most of the EP societies we believe that the QRS duration alone is not the surrogate markers of the left bundle branch capturing. That is the bottom line of the result of the studies.
Yeah, I look at the methodology from the HeartSync left bundle branch pacing trial. They did a few things that is not the usual thing that we do in the lab. For example, they'll do the high output HIS pacing to look for the correction of the left bundle branch block before the trial. They also look at the positivity of the lead 2 to show that they are capturing the proximal left bundle branch rather than at the vesicle level. So these are the things that is a bit out of the ordinary practice from some of us who are doing a left bundle branch pacing. Yeah.
Yeah, agree.
Sorry, do you mind if I just ask also a question? Sorry, thanks. Thanks very much for the very nice talk. And I'm interested to hear Keng Tat's opinion on this because I think part of the issue is a translation of the technique to the real world, especially as in Asia, there's a varying degree of experience with operators. A lot of pacemakers are still implanted by non-electrophysiologists. So my question is, the Chinese study is extremely rigorous in terms of confirming left bundle capture in patients with cardiomyopathy and left bundle branch block, and as Brazil, maybe less so. So it's going to be interesting to see. I think in practice, most of us don't actually adopt the same methods that Chinese do. I think we kind of take a pragmatic approach. I mean, I'm not sure what my colleagues are doing, but I think that's the case in terms of confirming left bundle branch area pacing is adequate. Obviously, we want to see correction left bundle. So I think the other comment, I guess, in Brazil, there was a lot of Chagas disease in their patients with DCM. So I don't know whether some comments I think we've made whether that affected the results. But I don't know. I mean, I'm interested to hear what everyone thinks about how we can apply this if we want to be more rigorous with proving left bundle branch capture. How do we do this in the real world, bearing in mind resources and expertise, etc.?
Yeah, I mean, I think the physiology reflect the real world practice, including Thailand and I think most part of the Asia. But trying to do the same thing with a heart sing might not be the practical way in most of the clinical settings. So I think just in between, I think we need to select the criteria that is most specificity for confirming the left bundle branch captures and stick with that criteria when we comes down to the practical point. That is my thought. And as you said, I mean, most countries, I mean, many countries in Asians, this procedure is performed by non-electrophysiologists. And I cannot speak of their, I mean, thought, but I think they wouldn't care much about the criteria of the left bundle branch captures. So trying to simplify the criteria for the left bundle branch capture might be the solution to get the similar result with a Hertzing LBBP study. That is my thought.
Yeah. I'm thinking that as a conduction system pacing advocates, we always want to prove that the conduction system pacing outperform the biventricular pacing, even though that biventricular pacing has a very long history of data. But on the other hand, some of us was pushed to do more conduction system pacing because of the cost, like what happened in our region, because comparing a dual chamber pacemaker than a CRT pacing device, the cost is obviously very much different. So I think when you look at all these studies that are having comparing conduction system pacing and bivent pacing in CRT indicated patients, there's always a crossover. And for Hatsing trial, you can see the crossover is extremely low for the left bundle branch pacing. It's only two patients in the LBBP group crossover to a CRT bivent pacing. But we see more in PhysioSync trial. About 10% of them will have a crossover to a bivent pacing. So I think looking at all this data, probably will have a lower threshold to cross over patients who think that we do not achieve a very good left bundle branch pacing or left bundle branch pacing with corrections to a more conventional bivent pacing. I think the whole message is that if we do not get a very good convincing conduction system pacing, it performs worse compared to a conventional bivent pacing.
Yeah, and one interesting point is the patient, I mean the population. In the Hertzing study, a lot of non-ischemic patients that might imply that less scar burden compared to the ischemic group in the PhysioSync studies. And the takeaway point might be selecting the proper patients, also crucial roles for get the responder. That is my thought. Hi, Mark. I think you were gonna say something. Nice to meet you. Hey.
Hey, Ron. I'm just want to first of all say sorry for coming in late because as I'm going to talk about PFA in my talk, I just did a PFA case which was particularly tough on a patient of 100 kilogram in weight. So yeah, so that's why I was late. I want to make a small comment about first of all, great talk. Make a small comment on the defibrillator leads that are supposed to perform left bundle pacing as well, because we are having the opportunity to participate in some of these trials, including the recent ASCEND trial from Abbott, and on using the left bundle defibrillator lead implanted in the left bundle area. My impression is that these leads are designed for going into the septum. So reaching the left septal area is quite easy. Okay. But on the other hand, if you just focus on doing a left septal capture instead of really doing a good left bundle capture, you may actually not doing a good service to the patient, because just doing a left septal capture in patients with left bundle branch clot may not be better than the traditional ventricular pacing approach. So I think my reflection after participating in the study is that it's good to have these tools, but on the other hand, we should also stay vigilant on if we are using these tools correctly. In particular, are we really capturing the left bundle branch in patients who need resynchronization?
Thank you.
Thanks, Dr. Mark.
Just like to put in.
Go ahead, Paul.
Oh, okay. Just want to put in the point that as we are transitioning to more use of conduction system pacing for cardiac resynchronization, I wonder whether we are sort of losing the skill of biventricular pacing. And actually, you realize that biventricular pacing through a CS lead is not a very easy task sometimes, and actually it takes a lot of tenacity to go and find the correct site. And sometimes, you can actually potentially find another better site, but it takes a lot of effort, and of course, naturally, it's time consuming. So to a certain extent, sometimes the outcomes also depend on how much time you put in, how tenacious you are. And also beyond that, also in terms of optimization, there will be a big component of how we optimize the devices. So I guess my point, why I'm trying to say this is that sometimes in centers which do the predominantly left bundle branch pacing, perhaps maybe it skews the experience of biventricular pacing, or converse to that, if you do more biventricular pacing, the experience to left bundle pacing is less. So hence, it becomes a little bit murky in this sense, because as you can see that there's a vast difference between the experience across the two centers. And yeah, at the same time, we do not really know. We also admit that it's actually sometimes very difficult to confirm left bundle pacing in a patient with a scarred septum, deranged conduction system. So that being, and at the same time also is sometimes in certain it's also very hard to optimize patients with CS lead, QLV, putting the lead in the correct place, rather than just accepting what that we all know that sometimes we have to put a lead in a suboptimal place, or we choose to leave it in the case of biventricular pacing. So just some points about that.
Yeah, I very much agree with you, Dr. Lim. The way that I try to keep myself still maintaining the skill of doing CS pacing is that I have a very I make sure that I capture left bundle. If I do not capture left bundle, I will do a lot CLT. So in these cases, I will have the chance to do the CS pacing again, and perhaps maintain the skill of CS pacing.
I was going to ask as well, because cardiac MRI is also quite useful to look at septal scar if resources allow. And often in patients with ischemic cardiomyopathy and left bundle branch block, often I would do an MRI to look at the septum first. I think I did a case recently where the entire left septum was scar. So that, well, there's no point even trying. So I will put in a CRT, and in fact, the threshold was fantastic, and QRS was like 130. So it's sometimes hard to predict, right? And it's just one of those things that we need to maintain the skill sets. But I agree with you, Mark. We might end up all doing lot CRT generally if we had devices that can support that, because that's not always going to be. We have issues with dedicated devices for that sort of thing, especially with your defibrillator. So that's something that might actually store up problems for the future. I don't know what you think, Mark.
Yeah, I think all of the company are doing dedicated devices for left bundle pacing or defibrillator devices. Medtronic and Abbott are obviously working on the leads already. So I would foresee maybe in the future there would be devices that can allow us to do lot CRT in a standard way instead of like improvising the way, like putting in the left bundle lead into the atrial port, and it's messing with the like AV delay to do the lot CRT, which is not ideal.
I think as Dr. Sofian had mentioned, it's quite important to be prepared and to do any of these, and as Paul said, to maintain the skill set. So just to share, we did have a case in our center where we actually had to remove the left bundle lead in a patient with non-ischemic cardiomyopathy and complete heart block, as he had recurrent runs of VT, which actually was an intramural VT. And his 12-lead ECG was actually quite interesting because after ablating the VT, he still had it was almost like echo beats. So he would have one pace beat followed by another beat that looks pretty much same as the pace beat. And we had to also swap him out anyway because after the ablation, his thresholds went up because the ablation site was quite close to the lead. And after we swapped him out for a conventional BIV CRTD, he has no more PVCs at all.
Usually, sometimes CRT is pro-arrhythmic, but in this case,
Yes, I think sometimes, unfortunately, by sitting in the conduction system, it's actually pro-arrhythmic. Yeah.
But the thing is, you should probably put up as a case report in some of the journal.
Yeah, we'll
interesting
do that
case.
in progress as
Yeah.
a warning for everybody. Yeah.
But looking at the I just go back to the heart sink trial. I just found out one thing about the difference is that the rate of ICD implant in a PhysioSync, actually PhysioSync doesn't allow the ICD implant from what I look at the exclusion criteria, whereby in heart sink they have about very near to 80-90% of ICD implantation. So one thing is look at is the super responder rate. If they having a heart failure and they have a super responder rate of recovery of EF less than more than 40%, they actually preclude them from the primary indication for ICD implantation. Yeah. So that's another way of looking at why people choose more CSP rather than the CRT, or we should actually combine it to become a cardiac physiological pacing, doing more lot CRT than just bivent alone or left bundle branch alone, something like that.
Saying that though, I think we like to stress that lot CRT has still not been shown in large trials, right, to be completely beneficial. So I think we're still waiting for more evidence on that. But going back to PhysioSync, I think when I heard the presentation, the rationale for the study is to do this in low resource setting, because in Brazil, reimbursement is an issue for the devices, right? So they really wanted to show that, in fact, it was funded by the Brazilian government, that they really want to show that dual chamber pacing with left bundle branch pacing versus CRT would be equivalent or superior even, so to save costs. And that was their rationale, which, speaking to them, it seems, I'm afraid that they haven't shown that. So I think they're still going to have to recommend CRTP for their patients. But it's just interesting to see everyone is trying to simplify the procedure, trying to reduce costs. But we do have to remember that the evidence needs to support this. Yi, Dr. Yi, is it time to go to the next talk?
Time to switch over.
Yep. So we're going to switch over to the next talk. Dr. Mark Tam is going to give the next talk on PFA. So Dr. Tam graduated from the Chinese University of Hong Kong with honors, and he received his cardiac electrophysiology fellowship training in the University of Michigan under the Hong Kong Heart Foundation Scholarship. He's currently the Director of Cardiac Electrophysiology in the Prince of Wales Hospital in Hong Kong and is a physician proctor for various ablation platforms and pacemaker devices. So PFA, as you know, is the big thing in EP, and we look forward to hearing Mark discuss where we are and the state of the art.
Oh, Dr. Mark, you're muted.
Sorry, thank you very much for your introduction. So can you guys see my slide? Very good. Okay, so it's my honor to present here in the APSC webinar. So the topic for me today is pulse field ablation in atrial fibrillation, more sizzle than steak. Okay, so before I begin diving into the boring EP stuff, I want to show you this graph. So this is not the prevalence of atrial fibrillation in the population, or this is not the number of AF ablation procedures done in the localities. This is actually the stock of Boston Scientific. So you're just looking at the correlation of the stock price with the launch of the PFA system from Boston Scientific. You will notice that seemingly there's a causal relationship between the launch of the PFA system of Boston Scientific and its rise of stock price for more than 2 times in the last few years. So, you know, PFA is really changing the game for the EP world, and we have many different PFA systems available in the market now. In Hong Kong, we have at least 6 or 7 different systems. In China, you have more than 10 or even more than 20 different PFA systems. So the topic for me today is PFA, is it a more sizzle than steak? So I will try to answer 4 questions in my upcoming presentation. First of all, I know that a lot of the audience may not be really doing EP, some are doing general practice. So I want to go briefly on who should undergo AF ablation first in the modern era. And secondly, I would like to talk about why PFA is an appealing end result for AF ablation. Thirdly, is PFA more effective? And fourthly, is PFA safer than conventional techniques? So first of all, who should undergo AF ablation? So this is the landmark study by Dr. Tyson Gary, published more than 20 years now. It showed that clearly AFib originates from one of the pulmonary veins. And after that publication, we tried to do more AFib ablation, try to do rhythm control for patients with AFib. But this was a very beautifully done study in New England Journal of Medicine, published more than 20 years ago, showing that in those days, during rhythm control may not be superior to rate control. And as on the contrary, you can see that patients undergoing rhythm control is having slightly more higher mortality comparing with the rate control. But this was more than 20 years ago. We have more upcoming data. For example, this AF-NET trial published 6 years ago demonstrated that early rhythm control is beneficial in terms of reducing the combined endpoint of CV mortality, stroke, heart failure hospitalization, or ACS hospitalization, which is early rhythm control is superior than rate control. So this trial only represents a small number of patients undergoing AF ablation. Most of these patients undergoing rhythm control are on antiarrhythmic drugs. We also have other AF studies showing that early AF ablation is superior over rate control. For example, this study is showing that in patients who present with new onset AF, if we do cryo ablation, the treatment success rate is much higher than doing antiarrhythmic medication. And in particular, in patients who are having HFrEF, heart failure with reduced ejection fraction, we know that AF ablation not only reduces the patient's symptom, but it's actually saving the patient's life. You can see that in CASTLE AF trial, it showed that patients undergoing ablation has a lower mortality comparing with patients undergoing just medical therapy. And these patients are all having HFrEF. And the number needed to treat for life being saved is actually very promising. You can see that NNT is only 8.6. To give you some perspective, when we're doing TAVI for patients who are not a surgical candidate, we have a NNT of around 5. And a lot of us are struggling to maintain the primary PCI service in the hospital. But actually the NNT comparing with thrombolytic therapy is 10 to 35. So you can see that in selected patients who are having HFrEF, AF ablation is having a very dramatic improvement for their outcome, not just reducing symptoms, but actually reducing the mortality as well. So as a result, the guideline was updated 2 years ago, and the ESC guidelines supported us to perform AF ablation as a first-line option for patients with paroxysmal AF, meaning that we do not need to wait for failure of antiarrhythmic medication. We can offer AF ablation as an upfront first-line therapy. And even in patients with persistent AF, we can also offer catheter ablation as a first line, but the grade of the evidence is weaker at class 2B. So second question I want to answer is why PFA is an appealing energy source for AF ablation. So I'm showing you 2 pictures. These are the voltage maps of patients undergoing AF ablation in the old days. We do point-by-point radiofrequency ablation, and you see that there are 1,000 dots on the patient's atrium. Each dot may take maybe 10 seconds to 30 seconds to complete. So you can imagine that it would be a very long procedure, and your patient often complain of pain after the ablation because of pericarditis and inflammation. You can easily damage the collateral organs, for example, the phrenic nerve or esophagus with thermal ablation. And of course, there are risks of recurrence. So these are the problems with traditional AF ablation. And PFA was initially developed as an energy for treating oncology patients. They put in the probe into a tumor, for example, liver tumor, and then develop an electric shock to the tumor, so-called PF energy, which can increase the chance of tumor cell uptaking the chemotherapeutic drug, because the pulse field energy would create pores into the cell membranes. So these cells will become leaky, and if there are enough number of pores, then the cell will go into apoptosis. If the pores are not big enough, the sizes of the pore is not enough, then the cell may repair itself. So that could be a problem of reversible or irreversible pulse field ablation. If the energy level is not high enough, the cell would not go into programmed cell death. So the beauty of doing this pulse field ablation is that you can see actually pulse field energy is very tissue specific. If we're talking about the heart, you can see that the myocardial cell are the most sensitive to pulse field energy. And the other important organs that we do not want to damage, for example, the smooth muscle cells in esophagus or in blood vessels, or the nerves, such as the phrenic nerve, they're having a much higher threshold for being killed by the pulse field energy. So we can deliver the energy, kill the abnormal myocardial cells, arrhythmogenic myocardial cells, without worrying about injuring the surrounding tissues. So this is showing how pulse field ablation is reducing the chance of collateral damage. We worry about damaging the esophagus by either radiofrequency ablation or cryoablation, but pulse field ablation was shown to be very safe in terms of creating atrioesophageal blisters. And the other thing is the phrenic nerve, and the pulse field ablation nearly never cause irreversible phrenic nerve palsy, unlike, for example, cryo energy. So the third question that we want to answer is, okay, it sounds like pulse field ablation is very promising. Is it actually more effective than traditional ablation? So this is the first randomized controlled trial comparing pulsed ablation with thermal ablation in patients with paroxysmal AF. This is the advanced study published 3 years ago, just after the launch of pulsed ablation in the market. And many of these operators are very good thermal ablation operators, having a lot of case volumes for thermal ablation, but they may be just starting pulsed ablation in their practice. So there's a difference in skill level. But even with that said, you can see that the group undergoing pulsed ablation is having comparable treatment success rate comparing with the group undergoing thermal ablation. There is a slightly higher chance of having procedure-related serious adverse effects, but this can be due to the learning curve issue. So this is another study which was published last year. And now we have more experience with the pulsed ablation, and these operators are randomizing these patients into either going for pulsed ablation versus cryo ablation. And you can see that these patients are all having a loop recorder. And you can see that patients undergoing pulsed ablation is having a much lower chance of atrial arrhythmia recurrence. With p-value of less than 0.001, and this is being picked up by loop recorder. So this rather accurate and very stringent definition of recurrence. And on the other hand, the complication rate is very favorable for pulsed ablation as well, just 1% chance of complication. So bring us to the question, is pulsed ablation safer? So this is the post-marketing approval registry in Europe, so-called Europea registry, looking at more than 1,000 patients undergoing pulsed ablation in 7 European centers. And you can see that the acute efficacy is very promising, 99.9% acute PVI success rate with a relatively short procedure time, less than 1 hour procedure time. And the safety outcome is also very promising as well. 1.7% of major complication and about 1.1% of pericardial tamponade. In terms of efficacy, in patients with paroxysmal AF, the success rate is about 80% when patients follow up for 1 year. And for persistent, it's 66%, which is quite similar, if not better, than the traditional ablation, thermal ablation approach. So this is another very big study. It's called the Manifest 17 case study. As its name implies, this is a study on 17,000 patients undergoing the Pennispline PFA pulsed ablation. But it's important to note that this is not a registry per se. This is a survey for operators, so there could be reporting bias. But having said that, with that limitation, you can say the overall major complication is very favorable for pulsed ablation. It's less than 0.2% of major life-threatening complications. Of course, the most common complication is still vascular complication, around 2%. So, but it is important to note that we are still very early in our launch of pulsed ablation. Pulsed ablation was made CE mark available about 4 years ago. If we go back to the thermal ablation story, you can see that initially we thought cryo ablation is very safe as well. But this is the first atrial esophageal fistula being reported for cryo ablation 4 years after the FDA approval for cryo ablation. So it's important to stay an open mind and be vigilant to look for the potential complications. So I would like to briefly talk about the different complications for different ablation energy source. For example, for thermal ablation, the most deadly complication that we would try to avoid is the esophageal injury. Fortunately, the incidence is relatively low at less than 0.2%. But if it really happened, the patient has a 50% mortality. fortunately, it was never reported in PFA procedures. And there are a lot of studies like post-ablation OGD studies showing that there is no mucosal damage, despite we are applying the ablation in the posterior wall very close to the esophagus. Thermoablation, the other problem is phrenic nerve palsy, and it can happen in as many as 5% of patients acutely following cryoablations. But most of these patients would have resolution of the phrenic nerve palsy, and leaving only less than 1% patients suffering from long-term phrenic nerve damage. But still, this is these patients could be symptomatic if the phrenic nerve injury is not reversible. Now, PFA has its own problems as well. So the first problem that we notice is hemolysis, because you are applying the pulsatile energy in the bloodstream. So there will be a lot of red blood cells that may be affected by the pulsatile energy as well. So this is obviously dose dependent. The more that you ablate, the higher chance that the patient can go into hemolysis. And this is also related to different catheter design and also different energy protocol. So a certain brand of catheter may have a lower chance of creating hemolysis comparing to the other brands. So it's important to know the tools that you are using and know the limitation. For example, you do not want to ablate too much, although it's seemingly safe, but you can cause hemolysis and can cause acute kidney injury. And then the other problem with pulsatile ablation, because when we're doing pulsatile ablation, we're doing electrolysis in the bloodstream, and that could be breaking down the H2O into hydrogen and oxygen, creating the microemboli. And the microemboli can cause problem because the microemboli can go into the brain and cause minor stroke. For example, this study recently published studying in a specific pulsatile ablation catheter, which is FDA and CE mark approved. In this study, they do serial MRI before and after the ablation procedure, and they found that alarmingly, 66% of patients had a new ischemic cerebral lesions in the MRI, and 2 patients are having clinical TIA or stroke. So it's important to stay vigilant of the microbubble formation. And the manufacturer, noting these kind of complications, they try to modify the energy protocol and modify the recommendation in how many irrigation to reduce the thermal effect and reducing the air embolism, or spacing out the application of the pulsatile ablation in order to promote tissue cooling, which can reduce the air embolism after PFA. This is also very relevant for PFA. This is a coronary spasm. It won't happen for RFA energy, but it will happen for PFA if we are applying it near coronary vessels. So this is a seminal paper by Dr. Vivek Reddy showing that if you're applying pulsatile energy around the coronary vessel, and for example, for this particular case, they're doing CTI ablation for the which is near the right coronary artery. You can see that most patients, if not all of these patients, would develop coronary spasm. The solution or partial solution is to give this patient nitroglycerin before the pulsatile ablation, but still significant spasm can occur despite nitroglycerin. So it's important to note that. So this was presented by us in last HRS, showing that although you do not see any ECG change, that doesn't mean that the patient has no coronary spasm. For example, this patient had very severe coronary spasm in distal RCA, but in the ECG, you do not see any change. So it's important to keep an open mind and stay vigilant. And we also did an OCT study looking at whether these coronary spasm can translate into long-term coronary stenosis and coronary damage. And we found that there could be subclinical coronary stenosis after ablation around the CTI region. As you can see, the coronary luminal area can reduce by a median of 10% upwards. And thankfully, all these patients are asymptomatic. We don't know if it is specific to pulsed ablation or it can happen to thermal ablation as well. It's very likely that it can also happen in thermal ablation because there are also reports in thermal ablation patients after RFA, there could be coronary stenosis as well. But it's important to follow these patients up in the long run and see if these lesions would progress with time. So we're doing a extended follow-up for these patients, and we will present this data in the upcoming HRS. So here's a quick summary on the pros and cons of different energy source. If we're doing pulsed ablation, we very often do not need to worry about phrenic nerve palsy. There's a very low chance of creating cardiac tamponade or perforating the heart. And there's virtually no reported case of PV stenosis or esophageal injury after pulsed ablation. But on the other hand, pulsed ablation can cause other issues. For example, microbubble formation, coronary spasm, coronary stenosis, hemolysis, or stunning effect, which eliminates all the electrical signal acutely, but there could be reversible pulsed effect, and then there could be recurrence after if the pulsed ablation is not durable. So with this background, different companies are having different solutions, and they are trying to create catheters that can deliver dual energy source. For example, this is the Medtronic Sphere 9 catheter, which is FDA and CE mark approved, which can deliver both the RF energy and also pulse field energy. Abbott and also J&J are also having their corresponding innovations in catheter design. So in conclusion, ladies and gentlemen, AF ablation has become first-line treatment in treatment-naive paroxysmal AFib patients. PFA is a promising ablation energy that has revolutionized the field of EP. Procedures are generally shorter and easier to learn. And there may be small incremental benefit on the ablation efficacy. However, while generally safe, PFA-specific complication can still occur. So we need to stay vigilant and always keep an open mind. So that's the end of the presentation. Thank you.
Thank you, Mark, for a fantastic overview of the current state of PFA. It's certainly very promising, and I think that those who have access to it will use it. Maybe I'll ask Paul to jump in here. Just give us your perspective on PFA in Singapore. Also, if you have any questions to Mark relating to the worrying findings we see in the coronary arteries.
Yeah, so pulsed ablation in Singapore, I think Singapore was, I think, one of the first in Southeast Asia to get the first device. Not sure about Hong Kong in comparison to Hong Kong, but that's but anyway, we first started out with the Farah Pulse and FarahView system, Farah Pulse system, and I mean, I think subsequent to that, we have so many other we've been inundated with different different iterations of pulse field because everybody wants to get onto the bandwagon, and all of them supposedly during the initial trials have shown very promising results. But when it comes to clinical data, I would say that all of us are rather disappointed at the real life, the larger clinical trials rather than the in vitro or the initial trials. I think what happens is that we are still in the infancy of discovering this new energy form and this technique of ablating atrial fibrillation. I think we all know how many years it took the thermal ablations to evolve to the current level of success. Initially with the non-irrigated catheters, naturally the success rate was pretty dismal in comparison to now. And it took so long with contact force, irrigation, and whatnot, and other techniques. So this field, it shows that it is very promising. I think also that sometimes because the catheters are made so easy, made in a way to encourage a single shot delivery, sometimes we do neglect the basic electrophysiology of ablation, such as looking at discerning signals. And I need to admit to you, sometimes when I'm in a rush, I forget to look at the signals before I say ablate and on, because it's so easy and so and there's so many and it's so easy to just know that you have good contact and all that. With regard to, so I think this will take a while, even though unfortunately the success rates have been well, a bit less than promising, the equivalent, so to speak. But I think the one thing that I do find reassuring is the safety. I think even beyond the manifest 17K, there's a manifest 40K, and it does, even beyond the bigger population, it shows that there is quite a fair amount of safety associated with this. Coronary artery spasm is indeed a very real thing that we worry about. And in fact, now there are even studies that reports of diffuse spasm not immediately linked to the ablation of the CTI or the mitral isthmus, but rather a delayed, like 45 minutes after. We still don't really know the mechanism or whether there's any, like the patient has a tendency towards Prince metal angina kind of spasm, but nonetheless, it's become a real thing. We have seemingly swapped esophageal fistula issue for a coronary spasm issue. But nonetheless, I think we are all getting we all need to adventure into this field where I think even though the companies really say that we should not be using it for these various sensitive regions, but I think most of us, quite a fair bit of us, are doing pulse field ablation in this area, and so far, we haven't seen any really gross significant detrimental side effects. I don't know about you guys. You guys too. I guess you're clearly Dr. Mark has been doing CTI with the flower. Yeah.
Yeah, illegally. But still, I think this is very tempting for us to use it in the like extrapulmonary ablation, right? It's very fast to create block in the lines, and it's very easy to learn as well. So it's a very reasonable for us to do so. But I agree with you that we need to be very mindful that these catheters are not FDA approved to be used on these regions, and we're doing it like sort of off-labeling, and we need to be mindful of the potential consequence. So I want to take a bit more time to elaborate on the coronary stenosis point, because we in the CTA OCT study we did find a mild stenosis in the coronary vessel, but it's important to note that OCT is a very sensitive tool, sometimes more sensitive than really needed clinically. And I personally have seen patients going for RF ablation for the CTI. They develop a stenosis afterwards, or even fistula between the RCA and the coronary sinus afterwards with the CTI ablation. So it's important. We do not have any OCT data for the RFA cohort. As of now, we are doing some analysis. We have a parallel study going on, but we do not have the result yet. But I think my gut feeling is that the coronary stenosis or coronary injury problem happens to both RFA and PFA. But coronary spasm itself is very specific to the PFA. So, yeah.
Can I just ask one question before opening up the rest of the panel? You know, there are some reports of late deaths, presumably related to VF and coronary spasm, late, as in within 1 month after PFA. Is it something that we ought to be worried about, or is it like atrial fistula, 1 in 10,000? And should we start counseling our patients about this?
It's difficult to say because all these so-called late deaths are very rare, first of all, less than 0.1%. And we're ablating sicker and sicker patients now, right? We're ablating heart failure patients, long persistent AF, doing a lot of ablation, extrapulmonary ablation. So although these deaths did occur, we do not know exactly what is the mechanism behind. And is it really related to the ablation procedure itself? So for now, I wouldn't be too worried about these late deaths because they are so rare and we do not know the causation for these events. But it's important to wait and see if there's more data to show us why.
Thanks. Keng Tat, you had something to say?
Yeah, can I have a quick thing on a CTI ablation with PFA? We did a case 2 weeks ago with a PFA after finishing the PVIs. We got out from the LA into the RA, did a CTI. How many PFA applications that would you take as a threshold to stop if you could not get a block? Is there any numbers or any caveats that we need to concern about CTI by the PFA?
Yeah, for CTI, in our experience, the mean number of applications is around 9. So very seldom we do not get a block after that. I think the maximal number of applications is maybe 12 to 15. But usually we can get a block in less than 10 applications. The problem with repeated application on the CTI region is not only on the coronary spasm, but it can cause tissue edema, similar to RF. So with edema, then the tissue will become thicker and it will become less and less likely to give the enough energy to create a block. So I think that's the caveat.
Okay, thanks. And quick things for all panelists and speaker. Without any limitations, do you have any case in your mind that you would kick off with the RF for the AFib ablation, not the PFA?
I think for me, okay, maybe I start first. For me, it's the mitral isthmus. So we know that mitral isthmus is the greatest enemy for AF ablaters because there are studies showing that if you do PFA in the mitral isthmus, the chance of getting durable block is less than 10%, even in the very experienced hands. So it's difficult to create block with PFA in mitral isthmus, lateral mitral isthmus. So in those scenarios, then we may consider doing RF.
Yeah, I agree with Mark about this because we started PFA in Malaysia about the same time, like in Hong Kong and Singapore. And when we first started with this technology, first thing we learned very fast. It's even faster than doing an AVNRT. So everyone going very fast. Second thing we learned, we have so much time left after the procedures. So people have an itchy hand and start to do extra pulmonary vein isolation. So CTI, posterior wall, mitral isthmus line, everything, SVC, So whatever that we can do, we'll do. But as time goes by, we find that actually, we not only have to be fast, we have to be accurate sometimes. Certain areas we need to touch up a bit more for the pulse field ablation. We found that the mitral isthmus line is not durable. It's a single-digit durability at the long-term follow-up. And we also found that from what Dr. Sofian has mentioned, the manifest trial, I think they have mentioned a few safety issues on the few reported case of a sudden cardiac death during the procedures. And these are not ablating the CTI line. They're ablating, there's a standard pulmonary vein isolation, and the patient had the sudden cardiac death with a myocardial infarction. So all these things slowly came off after a few years of doing pulse field ablation. But overall, I would say that the number of AF ablation, maybe not just in Malaysia, in worldwide, it goes like the share price in Boston. We used to be like doing maybe let's say we have 100 cases, now we can double or even triple the cases of AF ablation cases in a year. So that's how pulse ablation has changed the landscape of AF ablation. More patients can benefit from these procedures.
Yes, I think we have to stress that PFA is extremely safe procedure, and actually most of the time the complication rates compared to RF and cryo are definitely less. I think time is coming to end, but I would like to invite my co-chair, Dr. Yi, to maybe sum up the session and maybe deliver some closing remarks.
Just before we do that, we actually have a few Q&A. I don't know if
Okay. Oh, we didn't know. Okay,
we
go on.
had a few coming in for PFA. Looks like we generated more questions than the conduction system pacing. Anyone has some quick thoughts on this on the impact of PFA on the ganglionated plexi? And two actually asked about redo cases, whether you'd recommend PFA or to do RF or some other energy source.
For the ganglion plexi, I think I remember there was a study looking into the heart rate variation after PFA versus thermal ablation. It was shown that after thermal ablation, you sort of damage the ganglion plexi, and which would blunt the heart rate variation afterwards. So it can also like have some effect on the autonomic modulation with thermal ablation. But for PFA, this is much less because it is less these nerve fibers are not sensitive to the PFA energy.
I think back to the question that Mark has asked about whether you choose RF compared to PF. If you are a believer of cardioneural ablation as part of the adjunct therapy for AF ablation, probably will choose over thermal ablation compared to the PFA.
Yep.
And for a redo case?
Redo case, I still use PFA. There are certain systems that are very versatile when we do PFA. For example, a FARA system, they can do beautiful maps and deliver focal ablations, creating lines rather easily. So for those cases, I would still do PFA.
Okay, thanks for the answers. I would like to once again thank my co-chair, Dr. Sofian, and all our wonderful speakers and panelists. I hope that everyone has enjoyed the talks as much as I have, because I certainly have gained insight with the lively discussion that we've had. Although CSP and PFA have both been around for some time, but as you can see, the field is still constantly moving with new developments and as well as new evidence base, since actually, I feel like the technology is almost moving a bit faster than the evidence base we have. So we're still doing a bit of catch up there. I hope to see everyone next month at our update on lipids management, and have a good evening. Thank you.
Thank you.
Thank you.
Bye-bye.
Yeah.
Bye-bye.